Hi, my name is Adil Akthar, and I'm one of the radiation oncologists at the Northwestern Medicine Cancer Center and Proton Center in Warrenville. Today, I was assigned to talk to all of you on a topic that's termed precision radiation therapy. And really what that is a broad term that refers to using technology in a way that we can really deliver radiation precisely to improve patient outcomes and transform cancer care. It's a broad topic, and for today, what I wanted to do specifically was focus in on a couple technologies that are available to us at the Northwestern Medicine Cancer Center in Warrenville and the Proton Center, specifically the Gamma Knife Icon and Proton Therapy as forms of radiation that, again, are designed to deliver radiation treatments with submillimeter precision. And so before we get too far into that, I wanted to take a step back because I'm sure we have a diverse audience and talk to everybody a little bit about some of the fundamentals of radiation therapy before diving into these treatment platforms and how they're used in cancer care. So just to begin with, one of the questions I always get asked during consultations is simply, what is radiation? And it's a good question. What I tell my patients is that radiation is energy. And in 2020, we have different tools to take that energy and deposit it within cancer cells to cause breaks in the DNA or the genetic material that those cancer cells need to replicate and divide. And so that is the fundamental way in which radiation works to cause damage to cancer cells. So whereas surgery is physical removal of cancer cells outside the body, radiation therapy is physical damage to these cells in its place. And so in a perfect scenario, we would have a tool in which we can deliver 100% of the radiation dose to tumors and 0% of radiation dose to surrounding healthy normal tissues. There is no perfect treatment like that, but the goal is for us to use technology to essentially maximize the amount of radiation dose we're giving to tumors and minimize the amount of radiation dose we're giving to surrounding normal healthy tissues. And so, again, two of the tools that I'll focus on today are the Gamma Knife Icon and Proton Therapy. Before I get too far, I should mention that we're here at the Living Well Cancer Resource Center, and if you have any questions as I go through this, feel free to please post them as you're listening, and I'll be sure to address them at the end. And I do encourage you all to explore further this resource. Living Well has over 100 free programs for cancer patients and their families, so please do look into that more as we go through the talk or at the end. So with that being said, Gamma Knife is a special type of treatment used to treat areas of cancer or tumors within the brain specifically. And what it does is it uses about 200 beams of radiation that are generated from radioactive cobalt sources. And all 200 of those beams actually converge or intersect precisely on the location of the tumor. And so Gamma Knife allows us to take a very high dose of radiation and deliver it all in one sitting to a tumor to effectively get rid of it. And because we have submillimeter precision, we're able to do this safely without injuring the normal healthy brain tissue that is surrounding the tumor. And so it's a very unique tool. It's often referred to as not just Gamma Knife, but Gamma Knife radiosurgery. And the term there refers to the fact that it's almost like a surgery in the sense that it's a one-time treatment, designed to effectively get rid of a certain area of cancer. But it has certain advantages to surgery, such as not actually needing to be invasive or making an open incision or needing general anesthesia, for example, to accomplish that goal. And so that is something we're fortunate with hospital administration support we're fortunate to have. And more specifically and more recently, we have the latest model of the Gamma Knife, which is called the Gamma Knife Icon. And the Gamma Knife Icon, what that allows us to do, as opposed to some of the older models of the Gamma Knife, is actually have the flexibility of taking our treatment and splitting it apart into multiple sessions, typically somewhere around 3 to 5 separate treatments. The reason that becomes important and an advantage is because with older models of Gamma Knife, we were really limited to giving the full dose of radiation in one sitting, which is certainly convenient, but not all types of tumors can safely be treated in one session with a high dose, such as very big tumors or tumors near critical structures like the brainstem or the nerves that control the vision. And so by taking our given dose and being able to split it up over a few different sessions, we're able to give it more safely and make more patients eligible to receive this treatment, such as those with larger tumors or, again, those near critical structures. And one of the ways specifically that Gamma Knife Icon allows us to split up the treatments over several sessions is by allowing us to immobilize a patient's head in a custom-shaped plastic mask that really molds to the patient's face and head structure, and we keep it in our department. When the patient comes each day for treatment, we bring that mask out, they lay in it, and it keeps them immobilized, and it keeps them in the same exact position from treatment to treatment. The most common types of tumors or areas of or types of cancer we treat in the brain with Gamma Knife are, first of all, brain metastases, which are refer to cancer that has spread to the brain from various different locations in the body. So we can treat really any type of brain metastases, basically any type of cancer that has spread to the brain from various other different types of primary tumors, whether that be lung cancer or breast cancer, for example. Another common type of tumor we treat with Gamma Knife is the category of benign tumors. So tumors such as those arising from the lining of the brain, like meningiomas. Also, tumors that are growing off the pituitary gland, which is a gland that sort of sits in the center of the brain at the base of the skull, that secretes a number of hormones that are important for our body. And so pituitary adenomas or pituitary tumors are something that can be treated with Gamma Knife. Another type of common benign tumor is one that's called a vestibular schwannoma or acoustic neuroma, which is a tumor that's arising off the lining of the nerve that helps us with hearing and balance. There's really a whole list, and these are just a few. Interestingly, sometimes we can even treat not tumors or cancer, but functional disorders with Gamma Knife, such as trigeminal neuralgia, a condition where people have pain that is due to basically abnormal excitation of a nerve that supplies sensation to the face. So these are really just a sample of some of the conditions that we can treat with this powerful tool and the ways in which we can do it. So switching gears a little bit, next I'd like to talk about proton therapy, exactly what that is and who may benefit. So proton therapy is a form of radiation treatment, and it's a type of therapy, though, that uses a different type of radiation than what's used at most other centers across the state and country. So typically when an individual is receiving radiation treatment to treat their particular tumor or cancer, they're receiving X-rays as their form of radiation, high-energy X-rays that, again, are designed to damage the DNA of those cancer cells. Protons are different fundamentally. They are not X-rays. They are these heavy charged particles in the nucleus of an atom. And so one needs very special equipment, such as a particle accelerator, to be able to isolate these protons and accelerate them and use them clinically to treat patients. This equipment is really so specialized that there's only about 40 centers or so in the country that have the resources to deliver proton therapy. Here at Northwestern Medicine Proton Center, we're fortunate to currently be the only center in Illinois as of now to have access to this technology and offer it to our patients. So hopefully what I can do today is tell you a little bit about what are the differences between protons and X-rays and when we use them. So fundamentally speaking, the difference between X-rays and protons is the ability to spare normal tissue. And so X-rays, the way they behave in matter is that they enter one side of the body, go through a target or a tumor, and then exit the body. And they deposit radiation dose along that entire tract, including entrance dose, the intended target dose, and exit dose. Protons are different because they are heavy relative to X-rays and have a charge, a positive charge. The way they behave is they actually travel a certain distance that we can calculate before dropping off all of their energy and stopping. So as a result, there's no exit dose with proton therapy, and also there's much less entrance dose. You can think of it much like a homing missile in the sense that it travels to the target before depositing the vast majority of its energy. And because of this, the basic difference is with proton therapy, we are able to spare more normal healthy tissue surrounding the tumor. And in many scenarios, we feel that will translate into a reduction of long-term side effects down the road. So that is the basic concept behind proton therapy and the interest in using protons to deliver radiation to patients. Now, one of the questions I often get asked working at the Proton Therapy Center is, why isn't everyone treated with protons and who stands to benefit the most? And so that's a great question, something that's actually under a lot of investigation and is the subject of a lot of ongoing clinical trials even. But a couple scenarios which we feel there's the strongest compelling evidence that there's a benefit is number one in kids. So we treat a lot of pediatric tumors with proton therapy. Those are situations in which oftentimes we're able to cure the tumor, and these kids are going to live many decades in which a late side effect could manifest. And so we feel limiting radiation dose to the surrounding tissue, again, is of special importance. Another situation in which proton therapy often is very helpful is in patients who have received radiation a first time and they've reached or approached the limit of radiation that some of the normal healthy tissue can receive. And so with proton therapy, we're able to oftentimes give these individuals a chance at receiving further radiation in the safest manner possible by trying to minimize, again, overlap with previously irradiated tissue, given the absence of exit dose. Aside from that category, certainly we see many other types of patients who are diagnosed with various types of cancers. And in those situations, it becomes a case-by-case analysis on where we think sparing normal healthy tissue is going to benefit patients. We treat a variety of tumors at the Proton Center, a variety of types of cancers, ranging from brain tumors to head and neck cancers, some breast cancers, lung cancers, prostate cancers, just to name a few. And again, on a case-by-case basis, depending on the location of the tumor, the type of tumor within those areas I mentioned, we oftentimes do in fact feel that protons will offer a benefit over X-rays in terms of sparing normal tissue and a reduction in side effects. But some of these things, again, are under study, head-to-head studies in larger phase 2, phase 3 clinical trials. And we await those studies to hopefully establish a firmer role of proton therapy and make it more clear sort of who stands to benefit the most. And so those are really the two main radiation platforms that I wanted to cover today. The topic of today's talk, precision radiation therapy, is so broad that it spans many other tools available to radiation oncologists that I didn't go into today. But ultimately, one of my take-home messages is to consult your individual radiation oncologist. We go through many years of training to really know who will benefit from what different technology platform. And I talked about the advantages to some of the technologies we use, but there's also certain limitations as well to some of those technologies. And so it really does become a careful case-by-case analysis in terms of who we feel will benefit the most from what type of radiation technology. So with that being said, I'd like to open it up, and I thank you viewers for tuning in today. If there's any specific questions, please let me know. I'd be happy to address them.
So I think you might have answered this question. Jan is asking if it's possible to have treatment to an area that was previously radiated 40 years ago.
Hi, Jan. That's a good question. Let me repeat that for our viewers in case they didn't hear. So the question was, is it possible to give radiation again? I think that's kind of a broad question, a second time. But in this case, for example, to an area that received radiation about 40 years ago. So a couple thoughts on that. Number one, I would say that typically speaking, radiation we like to give once if possible. There are certain limits in terms of what the normal tissues and organs can receive. And we know often with radiation treatment, our first shot is our best shot. And so typically radiation treatments are designed in a way that when one goes through radiation, we approach some of those limits in terms of what the normal tissues can receive to really deliver as much radiation as we can to the tumor. Now that being said, particularly in 2020, as medicine has advanced so much and we're curing a lot of tumors and patients are living longer, there certainly are more and more scenarios where individuals many years down the road from their original diagnosis encounter a situation where they need to have radiation again, either for another tumor that's close by or maybe a recurrence of their prior cancer. And so more and more we're facing these scenarios. And there's a number of factors that at least I personally look at as a radiation oncologist to determine, if it is indeed feasible and safe to deliver radiation again. The first is how much time has elapsed since the first course of radiation. We know that there is some recovery of the normal tissues as time elapses. And there's no magic number, but generally speaking, the longer someone is from the first course, the further out someone is from the first course of radiation, the more comfortable we feel to give radiation a second time. And just to give you some perspective, for example, a lot of radiation oncologists would consider about 6 months at least to be a minimum. And beyond that, we like to see certainly on the order of years in terms of interval between 2 radiation treatments. Something that approaches decades worth of time that's elapsed between treatments, whether that's 10, 20, 30, or in this case, 40 years, we feel oftentimes that while we can't discount that radiation dose entirely, we feel hopefully that a lot of recovery has indeed happened to those tissues that have been irradiated in the past. And so in short, it sounds like a situation where it certainly could be considered, but there's a lot of nuances that would have to be looked at. For example, the area receiving radiation now, where is it located exactly, what critical structures are next to it. And then it would also be a benefit-risk discussion, because anytime we give radiation a second time, there are some increased risks. Those risks go down, again, as I mentioned, with more and more time that's elapsed between courses. But nevertheless, the risks would be higher than just a first-time course of radiation. And so it becomes, again, sort of an individualized discussion with the patient in terms of what the benefits are of giving radiation a second time and if those far outweigh some of the risks.
We had Sam Sewell wrote in and asked, what are the differences between traditional radiation versus proton therapy, in terms of effectiveness of proton cancer treatments?
Good question. So, thank you, Shamsul, for that question. The question to repeat is, are there differences in the effectiveness of traditional radiation versus proton radiation?
Specifically for prostate.
And specifically for prostate. A couple points to speak on for that. I think that's a great question. You know, everything I've touched on so far is really in the difference of protons to spare normal tissue and reduce side effects compared to X-rays, or sometimes as it's referred to, traditional or conventional radiation. But what about the effectiveness? Is one more effective than the other in killing cancer cells or tumor cells? The short answer is that both look to be equally effective in terms of cancer cell kill. There are some differences on a biological level in the way the DNA damage is distributed with protons versus X-rays, but that really needs to be studied a lot more to determine, you know, how that translates into differences in effectiveness. And so in short, we feel that for proton therapy, just generally speaking, the effectiveness is similar. It's really the difference in normal tissue sparing and reduction in side effects. To speak to prostate cancer, which I see a lot of at the Proton Center, what I tell men is along the same lines. We don't expect there to be a higher cure rate with protons versus X-rays or conventional radiation, but our hope is that we can reduce some of the late side effects. And particularly for the prostate, the two organs that are nearby are the bladder, which sits right above the prostate, and the rectum, which sits right behind the prostate. Those are two organs which, when exposed to radiation, can develop some long-term complications like inflammation or development sometimes of other complications in those areas. And so with proton therapy, less of those structures are receiving entrance and exit dose of radiation. Whether that clearly translates into reduction of side effects down the road, we have some data to suggest, but again, some of the larger scale trials are still being run. We actually have a trial open at our center that's being run nationally that's randomly assigning men with prostate cancer to X-rays versus proton therapy to more concretely define what some of the advantages may be to sparing the bladder and rectum and what the magnitude of those benefits are. But in the meantime, again, we have other types of evidence to suggest that sparing of the bladder and rectum would translate into some reduction in side effects. But some further study is needed, again, to really solidify what those benefits are and how much they are.
The next question Samshul wrote in has to do with Gamma Knife. I know you talked about what types of cancer or non-cancer Gamma Knife can treat. Is it specifically only for brain? Is the first question. And then what stages of cancer would it be most beneficial? And so you talked a little bit about metastatic disease, but is there any, if it's only for brain, is there any primary brain that maybe Gamma Knife would be beneficial for?
That's a great question, and thanks, Shamsul, for that question. So just to repeat, the question was, is Gamma Knife only used in the brain? And then also, are there what stages of cancer could Gamma Knife be used in? Well, I talked a little bit about metastases or stage 4 cancer, but can it be used in earlier stages? So a couple points to speak to about that. Number one, Gamma Knife itself is indeed restricted to treatment of areas in the brain. That is what the technology was designed to do. That being said, there are ways to deliver treatments like Gamma Knife to areas in the body. That's a different type of term we use. We use the term stereotactic body radiotherapy, or SBRT, which is often one will come across if they're doing research, which refers to again, using submillimeter precision, using a lot of the principles of Gamma Knife, but applied to the body to deliver really high doses of radiation, either all in one sitting or more commonly across multiple treatments, a handful, for example, typically 5 or less. And so that type of treatment is possible, SBRT, and there's a number of ways to give SBRT, whether it be proton therapy, whether it be IMRT, intensity modulated radiotherapy, which is a form of X-ray based treatment, CyberKnife. And so again, this goes into, there's just so many platforms that are outside the scope of the time we have, but it is something certainly possible to do outside the brain, but just not with Gamma Knife specifically. In terms of stages of tumors or cancers that we treat with Gamma Knife, aside from metastases, primary brain tumors specifically, which is what you may be referring to, depending on the type, may be treated with Gamma Knife. I refer to benign tumors in particular. The reason benign tumors are often good targets for Gamma Knife is because they're localized to really a small area. Other types of brain tumors called gliomas, which are primary tumors of the brain and more aggressive tumors. Oftentimes in the frontline setting, we don't Gamma Knife them just because they can often be infiltrative, meaning they're kind of spread out in the brain over a wide area, and so it becomes difficult to really deliver an extremely high dose of radiation to a small area and adequately cover the entire target. And so oftentimes we will not Gamma Knife a glioma in the frontline setting. You know, sometimes in a recurrent setting, if they've again received radiation in a different fashion and we need to really treat a small area, it could be considered. But typically for a glioma of any type, whether it's ranging from a grade 1 to a grade 4 glioma, or other types of brain tumors like a ependymoma, for example, those are treated with fractionated radiation, meaning over the course of several weeks of treatment.
Judy wrote in, her 85-year-old mother has lung cancer with lymph node involvement. What are the chances after 15 treatments that they're going to see some reduction in the tumor? Does her age play a factor in that? And what are the anticipated side effects from radiation?
Thanks, Judy, for the question. So the question was in reference to a family member, and I'm sorry to hear, Judy, I hope she does well, but a family member that has lung cancer and is undergoing radiation, and some of the questions were, can we anticipate to see a response after about 15 treatments? What are some of the side effects from the treatment? And I think there was another one in there, if I'm not mistaken. But
does her age play a factor?
And does age play a factor? So, for example, an 85-year-old. In response to that, what I would say is, number one, I often do get asked, just generally, how are radiation treatments going? Is it working? Is the tumor responding? And there's a couple, I think, points to know about that. So the first is that oftentimes, as unsatisfying as this may be, our ability to really track the progress of the tumor cell kill during the radiation treatments is limited. Really, our goal is often to get the full treatment in before doing a diagnostic scan a few weeks or a month later to assess the response. And the reason for that is a few. So number one is radiation treatment takes oftentimes a while to work. And so with each radiation treatment, little by little, if it's a fractionated course, meaning over several weeks like you're describing, little by little we're causing damage with each treatment. And the biological consequences of that damage can oftentimes take a number of weeks, even after all the treatment is done, to manifest. When the cells go to divide in the upcoming days or weeks, they realize their DNA is so damaged that they cannot, and they essentially die. So oftentimes, again, the full effect is not realized until the treatment is over, and not just until the treatment is over, but in the coming days or weeks after that. So that's one reason why during the treatment, oftentimes we don't see a response. That doesn't necessarily mean that the cancer tumor won't respond, but it's just a little bit too early. The second thing is the radiation therapy itself often will cause changes on imaging from the inflammation that the radiation itself is causing within the tumor or some of the surrounding normal tissue. And so even if we were to get detailed images during radiation treatment, some of that treatment effect or inflammation may obscure part of the picture and not really give us an accurate indication of how much the tumor has regressed. That's another reason why our ability to assess the effectiveness during the treatment is limited, in the sense that some of the treatment itself is causing changes, and we really prefer to, again, wait a number of typically weeks, a month plus to let everything settle down and then image. That being said, those two caveats being said, that it takes a while for the radiation to work and for the radiation inflammation to go down, sometimes, depending on the type of imaging that's being done during the course of radiation, we can indeed see some shrinkage during the treatment itself. We consider that a bonus. And again, while it's a good sign, even if it doesn't shrink, it stays stable, that is not necessarily a representation of something that's bad or negative. A lot of times, physically, the tumor itself, size-wise, looks similar, but when we get some kind of functional imaging down the road, whether that be a month or several months afterwards, like, for example, a PET scan, we see that there's still something on the imaging, but functionally nothing is lighting up, meaning that there's no active cells there taking up any of the dye we give. So it's a little bit like a building still being there, but everyone inside the building being evacuated. There's really nothing active in that building. And so that's another reason why, again, even if we don't see a physical geometric shrinkage in the tumor, that is not really a true indication of what's going on a biologic level inside the tumor itself. So hopefully that addresses a little bit in terms of, can one expect a shrinkage, and what does it mean if we don't assess it, or we can't assess it, or we don't see it happen during the treatment itself. In terms of age playing a factor, this is a good question, and it's something that I will say, in short, I don't think we have the full answer to. I'll give you anecdotally, based on my clinical experience and the clinical experience of other radiation oncologists, what we observe. A lot of times, it is true, I would say, that older individuals, it may be a little bit more difficult for them to cope with some of the side effects related to treatment, or for them to recover. In the setting of lung cancer, for example, for older individuals, particularly maybe those that have smoked over their lifetime, their normal healthy lung has less reserve than maybe a younger person, particularly one who hasn't smoked. And so the inflammation from radiation, sometimes they aren't able to handle that as well as maybe, again, someone with healthier, younger lungs can. And so sometimes the side effects are either A, more pronounced, or B, we quote a higher risk of something happening, like a pneumonitis or an inflammation of the lung. But all that being said, I kind of gave you my anecdotal experience. I also have experience where men and women have really pleasantly surprised me. I've gotten 80 and 90-year-olds through really tough treatments of the head and neck or esophagus. And so, I don't think even in 2020 we really know all the contributing factors to an individual's body that will predict who gets through treatment well and who might have a little bit of a tougher time. In general, while age, I would say, is a risk factor for maybe having a little bit of a tougher time through treatment, that's not always the case. You know, we are often pleasantly surprised by people and their ability to tolerate treatment. And it doesn't really, age itself can't really be taken into isolation because it really depends on, again, where the tumor is located, the type of tumor, you know, the type of treatment that's being given. Is chemotherapy being given with the radiation? All those things play a factor in addition to age. And so age itself in isolation is a little bit hard to specifically comment on, but I think may play a role in the ways that I mentioned. Lastly, what are the side effects from radiation? This is a good question. One thing that just broadly, if I could speak about, radiation is a local treatment. And so we think about it a little bit different than drug-based therapies like chemotherapy or immunotherapy that go into the bloodstream and travel throughout the body wherever the blood goes. Radiation is something local in the sense that, again, the only tissues being affected are those that are surrounding the tumor or the cancer that we're treating. And so the side effects are very dependent on what area we're treating. The side effects I quote for somebody with a brain tumor are extremely different than the side effects for a lung tumor versus a prostate cancer. And so it's all related to really the normal tissues that are nearby. In general, most radiation oncologists will talk about some degree of fatigue and some degree of skin reaction that happens in the radiation fields. But aside from that, it becomes very dependent on what's nearby. You know, in the case of the lung, certainly the esophagus and airway and the lung tissue itself are some of the main things we consider in addition to the major blood vessels and the spinal cord. But how close the lung tumor is to those areas influences the risk of developing some soreness with swallowing or some cough from airway irritation, for example. And so hard to say, of course, without knowing the particular specifics of the case, but my take-home message is that, you know, it's a little bit dependent on what's near the area we're treating, what dose we're treating to, and those are kind of the main factors. Oftentimes, the side effects happen during treatment. They're mild to moderate. And oftentimes, radiation oncologists have a lot of tools to help patients get through it, whether it's prescription or over-the-counter. Ultimately, one of our jobs as a radiation oncologist is to get you through the treatment, check in with you, and see how things are going. And if there are side effects, manage them as best as possible.
Okay, so I believe this will be our last question, but it's multiple pertaining to proton therapy. So the first one is regarding prostate treatments. What measures are taken to protect the bladder and colon in proton, especially for people with a history of colon cancer? So perhaps maybe gel.
Sure.
The second pertaining to proton is the fractionation the same or the total dose the same per week in proton therapy as it would be in conventional?
Great question. So the first was how can we use proton therapy to protect the colon, particularly, for example, in an individual with a history of colon cancer, maybe the thought being there that, you know, there's been already some level of manipulation or injury to some of the normal intestines. You know, what can we do to prevent any further inflammation or risks down the road? And then the second question was in terms of the dose and number of treatments with protons compared to X-rays. So to speak to the first part, it's a great question. There's a number of factors that we take into consideration when trying to protect the rectum, the sigmoid colon, and the rest of the intestines, whether it be large intestine or small intestine. The first of these is proton therapy itself. As I mentioned, with protons, we're able to spare more of the rectum compared to X-rays. And so just by the very virtue of using protons, we hope that there's less dose to the rectum, and that will translate into less side effects. Typically, we're below the actual colon itself. The sigmoid colon, which is where the which bridges the gap between the rectum and the colon, is something that we track the dose to very carefully during our treatment planning, and we make sure it's within acceptable limits in terms of what's been studied to be safe. So aside from proton therapy within our center and the treatment planning and logistics, what we've incorporated at our center, what a number of centers use, is yet another layer of protection, something called hydrogel or SpaceOAR. This is a really unique innovation in the world of prostate cancer, something that we use at our center for all men that are appropriate candidates. This is a gel that is inserted actually between the prostate and the rectum. And the reason we do that is this gel creates a physical separation such that the prostate, which sits along the rectum, when we insert a gel in between them, it creates a buffer or a space in between the rectum and prostate, such that when we're delivering radiation to the prostate, if it is separated physically in space from the rectum, we can deliver even less radiation dose to that rectal area. And so that becomes another powerful tool to reduce dose to the rectum. So protons, hydrogel, also our treatment planning process. Again, we do a CT scan actually as part of the planning process. We sit down with medical physicists and we outline all the structures, whether it be the sigmoid colon or the regular colon, and we track the radiation dose that's going to be going there. And we make sure it's within acceptable limits. So that's sort of our final check, is after protons and hydrogel, what dose is indeed going there, and is it a safe amount? And so that would hold true, I would say, for the average individual. That would hold true for someone with a history of colon cancer as well. And so hopefully that answers that question. A second question I get asked a lot is about the dose and how that's split up over how many treatments and how that relates to X-ray based treatment. So there's a couple thoughts to share on that. The first is that with proton therapy specifically, the use of proton therapy doesn't necessarily mean that the number of treatments or the dose has to change. There are a number of regimens that have been studied well in the X-ray world that we carry over to the proton world and use with protons as well. The number of treatments for prostate cancer ranges quite widely from center to center, ranging from 8 weeks or so of daily treatment to as few as even about 5 treatments. That, again, refers to that term I used, stereotactic body radiotherapy, or SBRT, where we take our dose but just give a lot more per day to get done sooner. The difference between these two ends of the spectrum, and again, we have things in the middle that sort of range between 4 to 5.5 weeks. The difference between those really becomes a case-by-case basis. Your radiation oncologist determining what they feel to be the most safe for you to undergo based on a number of features, for example, the size of your prostate gland, the anatomy of the prostate gland, what your baseline urinary function is. And so those decisions really influence the amount of treatments more so than the actual radiation technique of proton versus X-rays. We do have a clinical trial that's open at our center and open nationally that's actually randomly assigning men to 8 weeks versus 4 weeks of proton therapy to see if we can safely reduce the number of treatments by giving just a little bit more per day. And so studies like that, ultimately, I obviously encourage participation in, but they're going to hopefully answer more definitively what the optimal course of radiation treatment is for proton specifically, in this case for prostate cancer. All right. Well, I'd like to thank you for joining us. And again, I do encourage everybody to check out Living Well. It's an incredible resource within our healthcare system. A lot of programs for patients and their families. A lot of really great dedicated staff working hard to deliver really holistic care aspects that I think are just as important as all the technical aspects that I discussed with you today. We really, here in Northwestern Medicine, like to treat patients as a whole, and I think Living Well is an essential part of that. So please do check us out and check out all our resources in our center, and we look forward to seeing you. Thank you.